So good evening. I'm Laurence Lezère, Director of Spina Bifida Hydrocephalus, Quebec, and we're very happy to welcome you for this webinar tonight. This webinar is supported by our partner, and we're very happy to have Sophie Leduc with us today. Nurse for almost 20 years, Sophie has a wealth of experience in critical care, emergency care, and surgery department. For the past 4 years, she's been working in the urology clinic at the CIUSSS MCQ. Every day, she's surrounded by a team of experienced urologists and nurses. She demystifies the terminology and this beautiful specialization. She popularizes the most technical concepts and shared her expertise with passion. The objective of our presentation today are understand what a neurogenic bladder is and explore the different options for managing it. So, good evening. Today, we will talk about the neurogenic bladder in individuals with spina bifida. So I have the tendency to speak pretty fast. So if you do not understand or follow, please indicate it to me. Now, I don't have any conflicts of interest. And to begin my presentation, I will first review the anatomy of the urinary system. I'll talk about neurogenic bladder, then treatment options, advantages and disadvantages, and then a question period. So, urinary tract is a group of organs that may collect and eliminate urine. So, kidneys, ureters, bladder, and urethra. So, I've just shared an image that shows all the organs that will bring the urine, carry the urine. So, we have the urinary system, then you have the kidneys, 3, the renal pelvis, and number 4, ureters. So all everything that brings the urine to the bladder. 5, you have the bladder. 6, urethra. 7, adrenal glands. And we'll talk a little bit less about that in my presentation. But then we also have the renal artery on each side, then inferior vena cava, 10 aorta, 11 common iliac artery in red and common iliac vein in blue, the liver, number 12, large intestine, and pelvis, number 14. So we can test your knowledge. You can have a good idea of what you know. True or false? To urinate, we have to strain with our abdominal muscle. For question 1. 2, we have full conscious control of our urethral sphincter. And 3, neurogenic bladder is a bladder that no longer works or functions. So I'll leave you about 30 seconds to find your answers. So here are the answers. So the 3 responses are false. The first response to the first question, urination phase is a phase where our internal and external sphincters are relaxed. It is the bladder muscle, the detrusors, which contracts. For the second question, well, we have control only over the external urethral sphincter. The internal sphincter, urethral sphincter, is an involuntary sphincter. And the third question is false as well. You know, the neurogenic bladder can still contract, but in an anarchic manner, random manner. So how does it work? First of all, there's a passive filling of the bladder. So urine will flow towards the bladder in a very passive way. Then the stretching of the bladder walls ultimately causes involuntary contractions of the detrusor muscle. These contractions trigger a nerve impulse, which stimulates the relaxation of the internal urethral sphincter. And then autonomously, we release the external urethral sphincter, and then urination can take place. So the detrusor muscle contracts and the bladder empties completely. So what is a neurogenic bladder? It is a dysfunction of the lower urinary tract resulting from injury or neurological disease. Now, the patient may not empty bladder completely, may not feel the urge to urinate. You can have incontinence, overactive bladder. So that's a problem of communication between the sphincter, what we desire and what we can do. So here are the most common causes of neurogenic bladder. On one hand, you have spinal cord injuries like car trauma or sports accidents, or even accidents, very often very stupid accidents. And then there are also the surgical complications that can cause neurogenic bladder. Then neurological diseases as well, like multiple sclerosis, Parkinson's disease, Koda-Equina syndrome, spinal stenosis, stroke, or brain spinal tumors, diabetes, and spina bifida. Now, in 2019, about 100,000 people have multiple sclerosis, 35,000 Canadians who have spina bifida, 86,000 Canadians have spinal cord injuries, and approximately 4,300 more are added to this number each year. So it's quite frequent. 40 to 90% of MS patients, 40 to 61% of patients with spina bifida, 70 to 84% of SCI patients. So how do we make a diagnosis? So there's a history of neurological disease. Since when? Then the high of the lesion, complete or not. So the patient reacts to nervous stimulations or not. So the body will make him feel a pain, even though physically doesn't feel it. Then the type of spina bifida, and there are apparently several types of spina bifida. And also the question about the surgeries, the pregnancies, or BPH, benign prostatic hyperplasia. And are there any symptoms of incomplete storage or drainage? So the patient expressed the fact that he would like to empty more the bladder, but he can't. Then presence of complications, recurrent urinary tract infection, sepsis, incontinence, kidney or bladder stones, deterioration of kidney function. Now, diagnosis for neurogenic bladder. Voiding calendar, for example, that checks the frequency and the quantity of urine eliminated, the frequency, of course, as well. In the hospital, it's possible to carry out a urodynamic assessment that will measure the bladder compliance and measure intravesical pressure. There will also be a flow measurement carried out. So we want to know how the bladder extends when it's filled, and ultimately, what is the quantity of urine that the patient can eliminate. The doctor can ask also for an ecography, a renal ultrasound, and measuring also the kidney function, impaired filtration function, for example, and also carry out a cystoscopy to find the presence of obstruction or bladder stones.
The Possible complications of a neurogenic bladder are the following repeated urinary tract infection, impaired kidney function, kidney and bladder stones, urinary tract sepsis, complex wounds related to immobility or moisture. Here are many treatment options separated in two aspects. With a patient with bladder not emptying is the first list, and the second is with a bladder that empties too often. I will read them out now. So, one by one. Self catheters is entering a cleanly catheter by the patient themselves or their family, and the purpose of draining urine at regular intervals or according to the patient the desired symptoms. So urinary is then eliminated intermittently, either in the toilet or in the urinal. I'm sorry, I know I'm speaking very fast. So the pros and cons of self catheters. Pros are allows the patient to maintain their elimination autonomy. It's inexpensive and it's favorable to sexual health to people who still have a sex life. The cons: it increases the risk of UTI. There's a risk of trauma, bacteriuria, and the catheters are limited by the patient's motor skills. The indwelling catheter is the same as previous, but it is inside the bladder. It will remain in place 4 to 6 weeks. Urine comes out continuously into a bag either on the thigh or at the bedside. The pros of indwelling a catheter: it's useful for patients with motor limitations, but it increases the risk of UTIs, also the risk of urethral trauma and false passages. There can be erosion, dilation of the urethra. It can be uncomfortable, especially for women in wheelchairs who sit for a long time, and there can also be bladder stones. Suprapubic catheter is also an indwelling one, but it will be introduced by the bladder instead of the urethra. It should be changed every 4 to 6 weeks. The pros and cons of this one: it is more comfortable for the patient. It is favorable to sexual health as well. However, the risks are the possibility of wrong route of the urine, of UTIs, of bladder stores. Patients often have leaks or spasms, urinary spasms, so urine can exit through the natural route with it. And sometimes it's impossible to install it because the patient has had multiple abdominal surgeries. The urinary condom and suprapubic percussion is not used as much. My colleague can maybe talk about it more, but the urinary condom may be used with men. Uh, the patient can do a percussion on the suprapubic dermatome to trigger the urination reflex. It's urine is eliminated with the condom in a urinary or urinal or a bag. I've only seen it 5 times in my career. There may be other circumstances where it is used more. For the condom, the pros is it's not invasive, it's inexpensive, but the cons, the drainage is variable, difficult to quantify. It depends on the patient's dexterity, and there's a risk of wounds because they're not always tolerated by the patient. Radical cystotomy and ileal conduit. It's with the abdominal bladder removal. The uretes are connected to the piece of the intestine. The urine is eliminated into a urine collection device stuck to the patient's abdomen. In men, this surgery The surgery includes removal of the prostate. For a woman, we have to remove uterus and sometimes ovaries and fallopian tube. So it's a piece of the bowel that is used for this. The pros and cons now. It's comfortable for the patient. It solves moisture and incontinence problems. It solves these problems, but the cons, the surgery has a high risk of bleeding, post-op complications of ileocehatin necrosis of ileal conduit issues. It's a difficult recovery. There's equipment issues, and where we attach it to the bowel, there can be a necrosis. It can die. The tissue can die, and there's a new stoma to handle. There's possible infection, equipment issues, etc. Is everything good so far? Yes. So Mitrofanov is the creation of a conduit allowing the introduction of an intermittent catheter by the patient into their bladder, often via the navel, created by reusing the appendix or sometimes a piece of the terminal ileum. It is continent, the conduit, so the patient catheterizes themselves according to their schedule and needs. So the pros and cons here. It's more aesthetic than stoma. There's more autonomy. The cons, it's a complex surgery. It depends on the patient's dexterity. There's a risk of metabolic imbalance because it affects the absorption of vitamins, potentially. It's a difficult recovery and a risk of bladder stones. The India pouch now, it's a creation of patient catheterizable pouch when the native bladder is not usable. I have not seen it often in my practice. It is not a surgery that we do in my center either. Augmentation cystoplasty is the enlargement of the bladder, like a patch, done with a piece of the bowel that the surgeon will suture to the bladder. It is done when multiple surgeries on the bladder make it its compliance, the ability to stretch, diminished. So we see the image here of how it's done. It's open and then sutured. So now about liquid management. Many patients are unaware of the amount of fluids they consume in a day. Urine should be the color as white wine. You should reduce or ban coffee, dark soft drinks, energy drinks, mineral water, which really stresses the bladder. I've had a patient saying she would drink 12 cups of coffee per day. So before we did anything else, we told her to reduce her coffee consumption. So now we're talking. Sorry, I didn't put the title, but these are the people who urinate too often. So anticholinergics are medication that slow down frequent urges to urinate. There's disabling side effects, xerostomia, which means dry mouth and mucous membranes. There's dizziness, constipation as side effects. Most common names of this medication is Vesicare, Myrbetriq, and Tobias. There's varying effects. For some, it's a big change. For others, there's no effects at all. The Botox that we know, we use it in our practice. So it's a botulinum toxin into the bladder muscles by the urologist during a cystoscopy. So the bladder is paralyzed and frequent urges are reduced. It's performed in outpatient clinics now, but we have to be careful with patients who have a lot of spasms in their legs or excessive sweating. So we have to do a full assessment before doing it to minimize the risks. There's also perineal physiotherapy. Specialists in this can help you learn and relearn how to relax the sphincter and muscles. So a few sessions are often necessary to learn how to do the exercises properly, but you have to persevere. It's very small muscles, small changes at a time, but it's a possible route.